So now we're at the miscellaneous skin disorders. While these couldn't be categorized into the groups already listed, they're worth remembering because most of them have certain pathognomonic findings that help you recognize them clinically. Also, a few of these will actually be indicators of underlying disease as well. The first of these is acanthosis nigricans, another classic example of how a skin finding can indicate a second visceral disease. In this case, acanthosis nigricans, which is a hyperplasia of the stratum spinosum, can be associated with insulin resistance or a visceral malignancy. Can you remember the other skin finding associated with visceral malignancy? Yep, we just talked about it, the sign of Lessard-Charlat, or the rapid appearance of multiple seborrheic keratoses. The next lesion is actinic keratosis, a small, rough red or brown papule that's considered pre-malignant. As you'll see on the next page, there's a risk of squamous cell carcinoma, thought to be associated with sun exposure. The next finding is erythema nodosum, a skin lesion that causes inflammation of subcutaneous fat, particularly on the front of the shins. There's a huge differential for what diseases have erythema nodosum as part of their presentation, and include fungal infections and TB, as well as leprosy, strep infections, sarcoidosis, and IBD. Think ENLIST as an acronym for the finding and major causes. The next lesion is lichen planus. This skin lesion is classically and always described as pruritic, purple, polygonal, planar papules. Histopathologically, lichen planus appears with sawtooth infiltrate of lymphocytes at the dermal-epidermal junction. It's also important to recognize that this lesion is associated with hepatitis C. I like to remember that lichen planus with a P shows pruritus, purple, polygonal papules, and is associated with hepatitis C, which also has a P in it. The next disease we'll discuss is pityriasis rosea. Though you likely won't see it, it's worth knowing because it's marked by two classic skin lesions. The first is the herald patch, usually a small patch that occurs initially, and heralds the later popular eruption that occurs in a Christmas tree distribution. The disease requires no treatment. It'll go away on its own. Finally, let's talk really briefly about the common sunburn. Basically, the idea is that UV radiation from the sun induces apoptosis in the keratinocytes in the epidermis. This is predominantly caused by UVB radiation. As most of you know, excessive sun exposure and blistering sunburns are risk for skin cancer. The next 5 diseases are all types of infectious skin disorders. They're actually very boards relevant, particularly because the first 4 are caused by one of 2 bacteria, which can make for difficult diagnoses if you don't try to keep them straight. We'll try to provide the classic vignette associated with these 4. Impetigo, which is a very superficial skin infection, is usually either caused by Staph aureus or Strep pyogenes. It's really infectious. The classic locations on the face, usually the chin, with some of the lesions rupturing, leaving a signature honey-colored crusting, which is virtually pathognomonic and is a good buzzword for you to remember. The second disease is very common and is probably the start of a spectrum of diseases. Basically, you should think about cellulitis as an acute, painful, red-hot, spreading infection of the dermis and subcutaneous tissues. The same bugs, Strep pyogenes and Staph aureus, are implicated here. There are a variety of others that may also appear given the right scenario. For example, Pseudomonas is a common perpetrator if there's a burn. While you should think of cellulitis as the start of a spectrum, the opposite end of the same spectrum of skin diseases is the most dreaded of them all. That would be necrotizing fasciitis, affectionately abbreviated to neck fash, a much deeper injury that's much more serious clinically. It can be caused by Strep pyogenes, but also by other flesh-eating anaerobic bacteria. The classic finding of crepitus on exam is a type of crackling sound which is quite literally the sound made by rapidly moving bubbles of gas formed underneath the skin. The gas comes from the methane and carbon dioxide produced by the underlying infection. The clinical scenario will include either a post-surgical patient or a patient with a skin infection that appears to be worsening rapidly. There may be some blood-filled blisters that form quickly, or a gray discharge from the surgical site. The next skin lesion is actually a syndrome called staphylococcal scalded skin syndrome. Here, an exotoxin that's released by Staph aureus destroys attachments between keratinocytes in the granulosum layer of the skin. Patients develop a generalized erythematous rash with loss of layers above the granulosum. Classically, it's thought to happen in newborns and children. 2 things help to confirm the diagnosis. First, you should expect that since this is a diffuse disease, there will be some systemic signs, like fever. The second is that the disease should cover the body almost head to toe, and not just be focal, like you'd expect in impetigo, cellulitis, or neck fash. The final infectious skin disorder we'll discuss is hairy leukoplakia, which classically appears in the mouth, even more commonly on the side of the tongue. The differential for white tongue lesions usually only includes leukoplakia versus thrush. The clinical distinction is made when you try to scrape it off. Thrush can be scraped off, while hairy leukoplakia cannot. Do you remember from the micro lecture what virus causes this disease? Right, it's caused by Epstein-Barr virus, a member of the herpes virus family, and it's often a sign of underlying immunocompromisation, such as in HIV or AIDS. Skin cancer is an incredibly common type of cancer, and in many cases, not a life-threatening one to have. There are three main types: squamous cell carcinoma, basal cell carcinoma, and melanoma, all of which have classic appearances that you should be familiar with for the boards. Basal cell carcinomas commonly occur in sun-exposed areas. They're locally invasive, but almost never metastasize. The classic description is that they ulcerate centrally, but grossly show pink pearly nodules with rolled up or heaped up borders that show telangiectasias. Once you see it, you'll never miss it. Under a histologic slide, the key finding is palisading nuclei. Squamous cell carcinoma is a skin cancer that's thought to arise from another skin lesion that we just discussed. Do you remember which one? That's right, actinic keratosis. A variant of this theme is a keratocanthoma, which usually grows fast over the course of weeks, but then regresses within weeks after that. When the disease progresses to squamous cell carcinoma, it's usually expected on the hands and face and may have serious local invasion, but will rarely invade past the basement membrane. The carcinoma classically shows cellular atypia in the epidermis and invasive cells or nests of cells infiltrating into the dermis. Histologically, the key finding is a keratin pearl, which you'll see shown here. There are three associations with squamous cell carcinoma that you should know. It's associated with sunlight exposure, arsenic exposure, and immunosuppression. It's also good to know that it's associated with chronic draining sinuses. What bacterial genus typically causes chronic draining sinus tracts that discharge sulfur granules? That's right, actinomyces. Here you can see cellular atypia in the epidermis, and nests of cells infiltrating into the dermis, as well as keratin pearls. The final type of skin cancer is melanoma. This one's serious. Why? Because unlike squamous cell or basal cell, melanoma can metastasize. The classic question is what aspect of the tumor affects its likelihood to metastasize, and the answer, no matter how it's phrased, is the depth, known to surgeons as its Breslow thickness. This kind of makes sense, so it's easy to remember. The deeper skin cancer goes, the worse the prognosis, right? The lesion itself is described with the ABCD memory aid: A for asymmetry, B for irregular borders, C for more than one color, and D for diameter greater than a pencil eraser. Risk factors for melanoma include fair skin and increased exposure to sunlight, as well as history of nevi, which can be a precursor lesion. There's also a tumor marker that can be used as a staining technique if there's concern for melanoma. Do you remember it from the path section? It's S100. Just think of S for skin. Of course, if the melanoma is on the skin, it's usually easier to know if it's melanoma, but remember that melanoma has many different forms. The ABCD mnemonic we discussed is best for the common type, which is called superficial spreading, but there are many other types, including nodular and amelanotic or colorless. Also, 20% of cases of metastatic melanoma present without a primary melanoma on the skin, presumably because it was small and defeated by the immune system already. If you do get a question about metastatic melanoma, remember that melanoma is a mean cancer. It doesn't follow rules. It can literally go anywhere in your body, from your gut to your liver, to your bone to your brain to your eye. If you get a micrograph of a met, though, it's pretty easy to figure out it's melanoma, as melanoma should be uniformly darkly pigmented in any picture you'd see on step 1.